biomarker used in disease staging, predicting relapses, and monitoring responses to therapy. Dr. Hesham?
Bismillah. Thank you very much, Mr. Chairman, for the kind introduction. Thank you, my dear friend Dr. Assas, for the invitation. I would never have missed it for the world. So I was asked to address fecal biomarkers use in IPD within 15 minutes or less. So inflammatory bowel disease, as we know, it's no longer ulcerative colitis and Crohn's disease. It's a spectrum of disorders. This disorder is of a heterogeneous clinical course ranging from prolonged periods of remissions, even without treatment, going all the way to frequent flares in spite of very intensive treatment and occurrence of complications. The treatment targets have been shifting towards mucosal healing and endoscopic healing rather than symptomatic improvement as it was probably 2 or 3 decades ago. The discordance between the clinical and endoscopic response and the associated improved outcomes when we target endoscopic response rather than clinical response were the main drivers towards the shift towards the treat to target approach. Now this is the fashion. It has been in vogue for probably 10 years now, the concept of treat to target. Mucosal healing, as we know, is associated with a lower relapse rate, lower hospitalization rate, lower steroid use, lower penetrating events, lower incidence of surgical interventions. So all in all, a good clinical outcome for the patient. Now, the tight monitoring strategy with frequent endoscopic assessment is now the standard of practice. The problem with that is doing repeat endoscopies on a regular basis, even when the patients are not really symptomatic, is a problem. It's time consuming, it's troublesome for the patients, it's very cumbersome to have to undergo several colonoscopies even without a flare of symptoms. It's costly, and the expertise are not widely spread. We're talking about centers, big centers like Cairo, Alexandria, where that is readily available. In the countryside, that might not be the case. So all of this negatively impacts the patient's adherence to a close, tight follow-up program. Now, we need to apply something else. Now, the biomarker, the concept of a biomarker, which is defined as a measurable compound or substance that can be objectively identified and quantified and quantitatively evaluated in a biological sample, such as blood, urine, tissues, or feces, has gained a lot of importance recently. Various biomarkers have been investigated and are becoming more relevant to estimate the degree of inflammation. Now, this is a schematic showing all the available biomarkers. Some of them are stool biomarkers, some of them are blood, some of them are urine, and some of them are tissue biomarkers. For the sake of this presentation, we'll concentrate only on the left-hand column, which is the stool biomarkers, and we're interested in the top two, the fecal calprotectin and the fecal lactoferrin. There are several other investigational stool biomarkers that, for the sake of time, we'll not go into. Now, the fecal calprotectin, it's a cytosolic calcium and zinc binding protein. It's secreted or expressed in neutrophils, dendritic cells, monocytes, macrophages, and squamous cells. It's a stable protein, and that's the beauty of it. It stays in the fecal sample at room temperature for up to a week. Some laboratories insist on the patient delivering a fresh stool sample and even asking the patient to pass the stool sample in the laboratory. That is really not needed. The sample will remain viable for up to a week without preservation in a refrigerator, like some of us would tell our patients. Okay. FC is a hallmark of neutrophil activation. If there is increased in fecal calprotectin, there is increased neutrophil activation and inflammatory process. It's a recognized marker for a lot of disorders, like inflammatory bowel disease, NSAID enteropathy, and even colorectal cancer. Now, what is the role of fecal calprotectin in IPD diagnosis? Well, we have a role in diagnosis, we have a role in comparison to endoscopy, we have a role in comparison to histology, and a role in disease monitoring. So these are like 4 subtitles. Now, it was first isolated and described back in 1992. That's when I started my clinical practice, actually, the first year of residency in Qasr Al Aini. Pooled data from almost 6,000 patients showed a sensitivity of 0.95 and a specificity of 0.91. So they're both above 90 for both sensitivity and specificity in discriminating inflammatory bowel disease from healthy controls. That's when we compared the values for healthy controls versus IPD patients. IPD in general, not a specific subtype of IPD. Now, the cutoff value of fecal calprotectin of around 50% would exclude organic inflammation from IBS patients. So this is the second comparison. IBS, which is the most common reason why a patient would visit our gastroenterology clinic. It has a sensitivity of 88% and a specificity of 72%, which is a little bit lower than the values observed in healthy controls. So the value of calprotectin, IPD versus healthy control, is quite satisfactory, above 90. IPD versus IPS, it's lower. It's 95 sensitivity, 88 sensitivity and 72 specificity. Now, comparison to endoscopy. When we consider a cutoff of 50, the fecal calprotectin shows an overall sensitivity of 88 and a specificity of 73 for predicting the endoscopic activity in inflammatory bowel disease. If we choose higher levels of fecal calprotectin, these are reported in active versus non-active patients. So patients above versus controls, the values are higher. Active versus inactive, again, the values of fecal calprotectin are higher. And it shows a strong correlation with the Mayo endoscopic score. The overall accuracy of fecal calprotectin is around 89%. In Crohn's disease, the correlation is most evident when the disease is colonic rather than small bowel. And we see that in our clinical practice. FC performs much better when you're discussing ulcerative colitis or when you're discussing Crohn's colitis. When you're discussing Crohn's enteritis, it's not so great. Okay, the use of fecal calprotectin in predicting endoscopic remission shows a sensitivity of under 70%, 68 to be precise, and a specificity of 85%. Using a cutoff value of less than 100 for for fecal calprotectin, up to 72% of colonoscopies do not need to be performed. When we're doing a follow-up strategy for patients with inflammatory bowel disease, we should consider using fecal calprotectin before ordering the colonoscope. If the values are less than 100, we rarely need to perform colonoscopy. In that case, we can spare almost 3/4 of the colonoscopes involved in a tight monitoring treat-to-target policy. Now, does it correlate well with histology? Yes, it does. The elevated levels of fecal calprotectin were found in histologically active ulcerative colitis patients compared to inactive ones. Can we use it for disease monitoring? Yes, we can. Calprotectin is a useful tool in disease monitoring, correlating with endoscopic and clinical remission, and predicting the patients that will relapse. And that's even more important. You see a stable patient, and you do serial calprotectins. The elevations of calprotectin in most cases will precede a clinical relapse of the patient. So we can use it to predict the patients who are going to relapse. Now, data from analysis or reanalysis, post-hoc analysis of the Gemini 1 study showed that calprotectin levels of less than 150 are associated with clinical endoscopic remissions, okay? Endoscopic evaluation should be indicated only in patients with calprotectin level more than 250 micrograms per gram of stool, and not in those with values less than 100. And a fecal calprotectin level of 130 predicts remission, while a fecal calprotectin level above 300 is associated with relapse. The AGA guidelines, practice guidelines published last year, advised a cutoff of 150 micrograms per gram as optimal for both sensitivity and specificity in predicting endoscopic activity in ulcerative colitis. Also, in Crohn's disease, the early normalization of calprotectin in patients receiving medical treatment is associated with lower disease relapse and good long-term outcome, while the high fecal calprotectin value predicts relapse after TNF therapy. Sometimes you give the patient anti-tumor necrosis factor therapy, they show a clinical response, but the calprotectin does not go down. And you know that these patients are most likely to relapse while on treatment or after withdrawal of treatment more commonly. All right. Sorry about that. Right. The other stool marker is the fecal lactoferrin. It's a glycoprotein. Its main function is to bind iron and transport it. It plays a role in the innate immune processes being released by immune cells, mainly neutrophils. It exerts antibacterial, antifungal, antiparasitic, antiviral effects, but not on all species of bacteria, fungi, and parasites. It exerts some antibacterial, some antifungal, some antiparasitic, and some antiviral effects. It's an anti-inflammatory molecule. It reduces the production of pro-inflammatory cytokine and promotes the apoptosis of uncontrolled damaged cells. Now, lactoferrin, a recent meta-analysis of 10 published studies on lactoferrin showed a good sensitivity and specificity values for lactoferrin in detecting IPD disease activity. The combined sensitivity and specificity for evaluating ulcerative disease activity were 81 and 82, which is good, not great, but good, okay? Fecal lactoferrin has shown a strong correlation, mainly after anti-TNF therapy in Crohn's disease. The cutoff is 10 milligrams per gram, okay? A recent post-hoc analysis of both the Unify and the Pursuit trials showed that fecal lactoferrin levels above 84 predicted a low likelihood of clinical, endoscopic, or even histological remission. For reasons that most people don't know, in spite of all the good data published on fecal lactoferrin, it really gets traction in real life. It is not widely spread use. Okay, this is a summary of the data we just presented. This is a paper from our group published 3 months ago about the assessment of IBD disease activity by interleukin-6, serum amyloid A, and its relation to fecal calprotectin. The aims of that study was to probably test whether these two new markers, interleukin-6 and amyloid A, would be useful in clinical practice, and how would they fare when compared to fecal calprotectin. This is the patient characteristics of the studied group. Okay, and these are the results. I want you to look at the top table first, please. The first is the calprotectin data. We used a cutoff of 120 micrograms per gram of stool. Sensitivity was 94, specificity was 89. Below that is the serum amyloid. The figures are less, 90 and 64. Interleukin-6, the figures are even less, 80 and 64 as well. And this is opposite the serum marker CRP, which showed even less sensitivity. So we had an idea, maybe combining markers would perform better than doing a single marker. A lot of the scores used in clinical practice in gastroenterology nowadays are composite scores. They don't depend on one single variable, they depend on multiple variables. So we started adding and comparing the markers in pairs. We first took a look if we combine the interleukin-6 with the serum amyloid, if we combine CRP with the serum amyloid, if we combine CRP with calprotectin, interleukin with calprotectin, and amyloid with calprotectin. As you will see, the best combination was when we combined calprotectin with serum amyloid. The area under the curve was 96. The sensitivity and specificity data for these combination of markers was highest. When we went into financial analysis, although the combination of serum amyloid with calprotectin was more sensitive than using the calprotectin alone or the serum amyloid alone, the added value does not really worth the extra money spent on doing two markers instead of one. So for the conclusion of this study, stool biomarkers are very important for assessing disease activity, especially if we adhere to a treat to target policy, which involves very frequent monitoring of the patients on regular intervals, even if they're asymptomatic, and a very early intervention to change and adjust the medications of the patient, hoping to keep the patient in a deep remission and probably change the course of the disease. Till this moment, the best we have is fecal calprotectin. It's by no means perfect. It still needs extra work. We probably will keep looking for additional markers or composite scores until we reach that goal. Thank you very much.
Thank you, Professor Hesham, for this elegant lecture. Next lecture will be by Professor Yasmin Saad. She will talk about role of nutrition in disease management and flares, personalized diet strategy.